Okay, so this session is going to explain the anatomy of the shoulder, examine common risk factors for injury, explore the most common shoulder injuries, including rotator cuff tears, osteoarthritis, and thoracic outlet syndrome, and expand upon prevention measures. The shoulder joint is one of the most flexible joints in the human body, allowing movement in three planes. This includes flexion and extension, abduction and adduction, internal rotation, and external rotation. It is the mobility of the shoulder that contributes to the high incidence of injury and degeneration of this joint. It's also important, and I'll be mentioning it a few times, that it's an area of very low blood flow compared to other joints of the body. Now, it's also, before we get into this, very important to understand the structure and function and anatomy of the shoulder itself. It's comprised of the scapula, the clavicle or a collarbone, the acromioclavicular ligament that links the acromion and the clavicle, the subacromial bursa, as well as the other number of bursa that comprise the shoulder, the supraspinatus muscle, the acromion, the biceps brachii muscle, the shoulder joint capsule, which is comprised of the head of the humerus. You'll often hear the shoulder referred to as a ball and socket joint. The head of the humerus is actually the ball, and the glenoid cavity functions as the socket. From the back, we have the scapula, the infraspinatus muscle, supraspinatus, teres major, and then we also have nerves and blood vessels feeding into the shoulder from our cervical vertebrae. This is their frontal view showing the nerves as well as the veins and arteries. The same view from the back, the veins and the arteries, and of course the anatomy from the side. It's really important to note, if you look at this image on the right-hand side, that the nerves, arteries, and veins are actually passing under the clavicle. This is going to become very important later on in the presentation. The main risk factors for injuries for the shoulder are either acute injuries, which occur as a result of trauma, such as stopping yourself during a slip, fall, an impact, catching a falling object, and it's fairly easy to prove that this type of incident happens, or a chronic injury that occurs over time, for example, years, due to exposure to risk factors and also previous injuries. This is where the main issue comes with proving work-relatedness for compensation claims is the chronic injuries. So previous injuries. Once tissues, such as muscles or tendons, have become damaged, they will never return back to normal. Scar tissue may also develop, which can result in a loss of function. Scar tissue adheres to muscle fibers, tendons, and connective tissue and prevents them from sliding back and forth properly. Scar tissue also limits the flexibility of a muscle or joint, resulting in a less range of motion and can also have an effect of pain. Scar tissue is also weaker, less elastic, and more prone to future re-injury than normal healthy tissue. And another previous injury would be osteoarthritis. Awkward postures. Panett, going way back to 1991, stated that workers who spend more than 10% of their time in non-neutral postures are at an increased risk of developing musculoskeletal disorders. This includes working the arms away from the body more than 60 degrees, such as overhead, abduction, adduction, flexion, or extension. Static postures is when you're working with your arm extended for a period of time in a non-neutral posture. The anatomy of the shoulder with a static posture places pressure on the nerves and blood vessels in the area. If you remember when I was showing the anatomy, I said pay attention to the fact that the nerves and blood vessels are passing underneath the collarbone. When the arms are elevated, these vessels are actually getting pressed up underneath the bottom of the collarbone. Now, static postures also reduce or result in a reduction of blood flow to the tissues, reduce synovial fluid circulation, result in reduced penetration of cartilage by solutes, and reduce clearance of waste products from the joint. And again, remember, it's already an area of low blood flow. So when we're resting, we don't need a lot of blood, and we don't get a lot of blood flow as a result. When performing dynamic efforts, a lot of blood is needed, and the body generates that. But we're in a static, awkward position, for example, with the arms stretched out straight in front of us, we need blood to perform the task, but because the blood vessels are actually compressed, we're not getting the blood flow that we need. Inadequate recovery time, formerly referred to as repetition. This is the use of the same body part to perform a task without allowing the body tissues sufficient time to recover. It can also be the time to perform a task or the time spent engaged in a task, for example, with the arm away from the body. As I said, we refer to it as formerly known as repetition. This is almost a whole session on a different webinar, but at OHCOW, we are trying to stop using the word repetition as a risk factor because it's actually the reduced recovery time that's preventing the tissues from healing and as a result getting re-injured or injured more. With respect to force, there's two types of force. External force, such as what weight are we actually physically lifting, and internal force, how hard the muscles have to work to move or hold the external weight. Internal force is basically ignored often by WSIB for determining work-relatedness, since it's something that's not easily measured and requires an understanding and education of biomechanics. Here's just a very simplified version. It's someone standing, holding a scaling bar, and they're not actually moving. They're just holding the bar in the air. So if we're going to try and figure out what would be the internal force this person would be exerting, there's a couple of things we need to know. The first force is the mass of the object, the weight, multiplied by gravity. To simplify it, we're going to say 10 meters per second squared. Force is also expressed in a unit of newtons, and torque is the turning effect of a force. So what the muscle has to do to actually exert that energy. And that's calculated by the force times the distance. So in this example, the scaling bar weighs about 2.3 kilograms and is 3 meters in length. So as a result, the force of the bar itself is about 23 newtons. If you notice there's a negative sign, that's because it's acting downwards due to gravity. We're going to assume that the middle or the center of gravity of the bar is right in the middle, 1.5 meters. In this example, the subject's going to weigh 180 kilograms, and they have an arm length of 796 millimeters. Using data provided from Winter from 1991, we're able to actually determine the weight of the arm and also the muscle force. We needed to calculate the muscle force at the shoulder, and we can also determine the center of gravity for the arm. Then by combining everything into the formulas, what we end up finding is that the torque of the muscle, so the amount of energy or force that the muscle has to exert, is about 68 newtons. So the muscles about the shoulder create a torque of 68 newton meters in the opposite direction of the bar in order to maintain equilibrium. So what does this 68 newton meters mean? Well, when we convert it back, it's about 249 kilograms. Therefore, just to hold that 2.3 kilogram bar, not the action of scaling, results in 249 kilograms of internal force being generated, or 100 times the weight, just to lift the bar. So as a result, internal force is very important when considering work-relatedness because of the fact it's energy exerted upon the body. Vibration is another risk factor. As the length of time exposed increases, approximately greater than 9,000 hours according to Stedland in 1992, so did the risk of developing osteoarthritis. This contributes to tissue degeneration when combined with sustained static postures and inadequate recovery. The circulatory effects are also reduced due to vibration because the rate of blood flow going into the peripheral tissues. And when these risk factors are combined, they act synergistically to exacerbate the situation and increase the likelihood of tissue degeneration. Vibration also stimulates bursts of muscle activity that can result in fatigue or tiring of the muscles. As a result, the muscles can also become tense. And when a muscle tenses, it becomes rigid. And as a result, the strength of the vibration signal being transmitted throughout the body thereby increases the effect of the absorption of vibration. Temperature is another risk factor. It's caused by a reduction in blood flow to the body's core. And again, the shoulder is an area of very low blood flow. Non-occupational risk factors include age. Our muscles and joints are less hydrated and elastic, resulting in a longer recovery period to heal back from any type of injury. Genetics. In some families, there's a greater probability of developing a defective connective tissue disorder or an impairment of circulation, such as Raynaud's. Some infections within the bursar tendon sheath can also give rise to inflammation or swelling. And also systemic disorders such as rheumatoid arthritis, gout, lupus, diabetes, and thyroid diseases can cause a reduction in blood flow from the body's core. And smoking, of course, also reduces blood flow and the healing process. Now, osteoarthritis occurs when the protective cartilage that cushions the end of the bones wear down over time. Risk factors for osteoarthritis include awkward static postures, insufficient recovery time, force, both internal and external, vibration, and cold temperatures. The primary effect is reduction of blood flow going to the tissues, reducing healing. Osteoarthritis tends to occur within the acromioclavicular joint and the glenohumeral joint. When stability of the joint is compromised, tiny microtears occur, including the creation of osteophytes in the joint, thus starting the process of degeneration. Now, Elsner in 1995 proposed this mechanism of injury: manual labor, including inadequate recovery periods, repeated microtrauma, extreme working postures, combined with hand-arm vibration that resulted in a need for strong joint stabilization and grip forces, as well as a tonic vibration reflex, the sustained contraction of a muscle which is subjected to vibration, combined with dynamic and static joint loading, as well as the effect of low-frequency percussion, as well as genetics, such as genetics, medications, and medical conditions, all work to combine into osteoarthritis. Now, for the acromioclavicular joint, the cartilage loss occurs between and around the acromion of the scapula and the clavicle. The glenohumeral joint, it occurs within the glenohumeral cavity. So right in the middle of the ball and socket joint itself. Bursitis is inflammation of the bursa, which is the sac of fluid that cushions the structures of the shoulder as they move to create a smooth, almost frictionless, functional gliding surface, making normal movement painless. However, with overuse, trauma, as well as some medical conditions, the bursa can fill with too much fluid, filling and squeezing the joint space. Tendonitis is the inflammation or swelling of the tendon due to pressure or irritation, such as when bursitis is happening. And tenosynovitis is the response of the tendons to the inflammation. The synovial sheath around the muscle fills with a fluid called synovium that acts as a protective measure to protect the muscle. But as a result of the irritation, it starts to swell and again increases the amount of compression that's happening within the shoulder joint. Now, one of the most common things we tend to hear for shoulder injuries are rotator cuff tears. The rotator cuff itself connects the humerus to the scapula. It's formed by the tendons of the four muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, which attach the muscles to the bone. The muscles move the bones by pulling on the tendons, and in this case, raises and rotates the arm. These tendons run beneath the bony acromion, or the point of the shoulder. The rotator cuff keeps the humerus, upper arm bone, tightly in the glenoid socket of the shoulder blade. The tendons themselves have very low blood supply, and as a result are not able to repair and maintain themselves as quickly as other muscles of the body. And they're especially vulnerable to the effect of degeneration from aging. Again, they become less elastic. Degeneration of the tissues is also accelerated by repeating the same types of shoulder motions. And it's estimated that up to 40% of the population may have a mild rotator cuff tear without even knowing it. Some stats have shown that 20% of 60-year-olds have a tear, and as much as 50% of those 80 years old or more have a tear. Now, there's two main mechanisms of injury again for rotator cuff tears. Trauma, such as a slip, fall, car accident, or a sports injury, or chronic use. Over time, the tendons wear thin and a tear can develop. It's often preceded by complaints of a shoulder bursitis. And with movements, the tendons themselves can become impinged under the bones. Now, development of a tear is actually a multi-stage process. Stage 1 includes swelling and hemorrhage and occurs mostly in young people, but less than 25 years old, after overuse, and is reversible with conservative treatment. Stage 2 involves fibrosis and tendonitis, and is typically seen in people between 24 to 40 years of age. It may not respond well to conservative treatment. Stage 3 refers to bony changes, such as spurs, and complete tears of the rotator cuff and or the long head of the biceps tendon. Work-related causes of tears: shoulder motion such as abduction, flexion above chest height, internal rotation of the shoulder, protraction of the shoulder, prolonged work at or above shoulder level, repetitive and or heavy forceful motions involving combined actions such as abduction, flexion, and internal rotation, static tension or positions involving prolonged abduction, prolonged vibration exposure from heavy handheld tools such as a jackhammer, and also previous shoulder injuries. Non-occupational risk factors: accidents, sports injuries, aging. Again, the rotator cuff pathophysiology and degeneration has an absolute association with the aging process, such as a partial tear. Anatomical variations, such as a hooked or curved acromion, acromioclavicular joint, and carotid process anomalies, postoperative or post-traumatic scarring, glenohumeral instability, and also smoking. Now, there's actually 8 different types of rotator cuff tears. Partial tear goes only part of the way through the tendon itself. It's usually described in terms of how deep the tear is in the tendon, and it doesn't refer to the length, width, or other dimensions. A full thickness tear, though, is when the tendon goes all the way through the tendon. Now, here's a question. If 20% of the population in the age range of 50 to 60 have a partial tear progressing to 50% by the age 80, how come they don't know it? Well, the answer for this is that the rotator cuff works like a suspension bridge cable that connects one side of a bridge to another and carries a load from one pillar to the other across the span. If the tear of the supraspinatus muscle, the top of the bridge, and at the anterior and posterior rotator cuff, the two suspension towers are intact and functioning well, shoulder function will actually be maintained. So basically, they're bearing the load. One analogy of what is a rotator cuff tear is to think of the rotator cuff as a pair of jeans covering your knee when you're bent when kneeling. The knee would basically represent your shoulder, the jeans, the rotator cuff tendons, the ground would be the bones, the acromioclavicular joint or the glenohumeral cavity. Now, have you ever noticed one day your jeans are fine, but the next day there's a slight hole? Then you may even have a minor fall or simply kneel and the jeans just suddenly tear and give out. Well, over time, the jeans wear out, and if you wear them long enough, they get ratty in spots, and eventually a hole may form. This is very much like what happens with the rotator cuff tendons. Until around age 45, the rotator cuff tendons look like a new pair of jeans. Around age 45 to 65, they begin to develop small tears that will progress in size. And over age 65, the rotator cuff becomes even more worn and torn. One of the main factors for this is osteoarthritis. The once smooth surface of the bones, such as the acromioclavicular joint, with osteoarthritis become jagged, they become rough. The tendons glide over the bones of the shoulder joint, rubbing against the roughened surface, and produce micro tears, especially with overhead tacks, abduction, and reaching in front or to the side. A good analogy of this is if you ever watched a movie where someone's climbing a mountain with a rock and the rope's running over top of it, but they're bringing themselves upwards. The rope is running over that roughened surface, which again is like the roughened bone. And as that keeps happening, the rope begins to fray, just like the tendon would, until a tear begins. Now, research is starting to notice that these injuries are not happening independently. They're actually happening as part of a continuum. Stage one being, for example, a normal shoulder. Stage two, we get tendonitis, an inflammation of the tendon that can result due to forceful actions or prolonged overhead work. Stage three, we start getting tenosynovitis, that protective response of the tendon by secreting synovium. Then we also get swelling of the synovial sheath as a protective response of the tendonitis as well. This in turn can lead to the development of bursitis, which can result from swelling due to the tenosynovitis pushing it against the acromion. It can also result due to forceful actions, prolonged overhead work, impingement, as well as secondary conditions I've already mentioned. Stage 5, the tendonitis, tenosynovitis, and bursitis can also worsen if there's osteoarthritis present in the shoulder due to rubbing against this rough surface, and becomes progressive, leading to the development of micro tears of the muscle that can also, as a result, lead to full thickness tears due to rubbing against the rough bones and the impingement. The next disorder is thoracic outlet syndrome. This is a disorder that results in compression of one or more of the neurovascular structures, the nerves or the blood vessels I talked about earlier, that travel throughout the passageway from the lower neck to the armpit, which is the thoracic outlet. Compression of the nerves and blood vessels within the thoracic outlet can interrupt the nerve signaling, while compression of the blood vessels can impact blood flow. It commonly results from chronic or prolonged movements with the arms elevated or overhead, and from awkward postures and static postures of the head, neck, and the shoulder. Now, there's three types of thoracic outlet syndrome. Neurogenic, which is one we tend to hear most of, which accounts for 80%, venous, which accounts for 20%, and arterial, which accounts for less than 1%. Venous thoracic outlet syndrome occurs within the costoclavicular space, and the most common cause is elevated and overhead arm use. The health effects are impeded circulation and reduced oxygen and nutrient deprivation. Arteriothoracic outlet syndrome occurs within the interscalene triangle. It's often caused by structural abnormalities, and the health effects are ischemia and possible development of an embolism. Neurogenic thoracic outlet syndrome, again, accounts for 80% of all TOS causes, and it can occur in any of the three spaces, the interscalene triangle, the costoclavicular space, or the pectoralis minor or retropectoral space. Causes vary, which we'll get into. Health effects: pain, numbness, tingling, and a cold sensation. Causes: first one is post-traumatic onset and acute trauma, a break, or a whiplash type injury. Structural abnormalities. Some people actually have different genetic mutations. Some have an extra cervical rib. Others will have an elongated C7 transverse process. There may even be muscular abnormalities, such as a narrow interscalene triangle or passage through a narrow anterior scalene muscle. And they may even have extra ligaments. Work-related causes: awkward, static, prolonged postures. This can have an effect of some joints for increasing muscle length, making them more lax. Other ones, they decrease the muscle length, and they can also increase nerve compression. This can then act to cause muscle weakness in some muscles or an overuse in others. These are just examples of overhead work. If you notice in the video on the right, in the upper right, that someone's bringing their arm upright, you can actually see the blood vessels and the nerve being compressed between the muscles within the space. External forces, such as carrying heavy shoulder loads, pulling your shoulders back and down. Symptoms themselves can range anywhere from the neck and shoulder down into the forearm and even the hand. Where the symptoms occur actually depends where the actual compression happens, whether it's at the interscalene triangle, the costoclavicular space, or the pectoralis. And then again, at what level it's occurring of the nerves as it's leaving the spinal cord. For example, musculoskeletal, axillary, median, radial, and ulnar. So where the symptoms will manifest themselves all depends on, again, where it's leaving the spinal cord and which of the three spaces the compression is actually occurring. Because if you notice in the image, there's actually crosstalk between a lot of these nerves as well. Now, the symptoms of thoracic outlet syndrome can also manifest themselves similar to that of carpal tunnel syndrome, because if the branch to the median nerve is compressed. The median nerve actually supplies innervation to the thumb, index, middle, and the inside of the ring finger. So if you go back to that previous image, there's a compression of the median nerve. If someone's actually experiencing numbness in their pinky and the outside of the ring finger, that's a whole other disorder known as ulnar neuropathy. So how can we prevent these shoulder injuries from happening? Well, we want to try and minimize awkward postures. Keep the upper arm below 60 degrees of elevation. Minimize the amount of time we spend in those static, awkward positions. Minimize reaching. Get as close as we can to the task we're performing. Monitor the number of tasks that require overhead work. Modify our tools and equipment, using bit extensions for drills and screw guns that allow you to hold the tool at waist level or shoulder level rather than above your head. Consider tools that weigh less. You can use a step stool, ladder, mechanical lifts, even stilts or hoists to raise and position yourself closer to the work so you're not actually reaching up and out for away from the body. You could use something like a tool balancer, which is actually going to support the weight of the tool itself. So as a result, all you're doing is guiding it and not actually supporting the weight. It's also important that people listen to their body. If a shoulder gets sore after any activity, it's important not to ignore it. Because if you do and think, oh, it's just going to get better, it's not going to get better. You need to pay attention to what's going on. It's important also maybe take a break for a couple minutes after every hour. Move around, stretch, get the blood flow and circulation going. Because remember, again, the shoulder is an area of very low circulation. If you're having trouble with your arms, avoid sleeping on your side with your arm outstretched or overhead. And try not to lie on your shoulder if you're experiencing pain as well. Reduce smoking. Korea MSD developed a nice little infographic as well as a video uh, that, and I'll share my copy of my handouts when I'm done in the chat, so you can actually get the link itself. Or you can just Google Korea MSD shoulder injury prevention. So anything in the green saying no actions required. Yellow is requires further investigation and improvement, and orange is basically immediate actions required. So you want to try and eliminate overhead work. Again, keep the arm below 60 degrees of elevation. Room required, design overhead work to reduce the injury risk and avoid reaching far away from the body. You want to limit high precision overhead tasks in duration and frequency. Apply force in line with vertical. For example, push straight up or pull straight down. And again, rest for a couple minutes after every hour of continuous work to give the body a chance to get the blood flow and circulation going again. For other examples that they suggest, adjusting the tooling and or workspace to decrease the time of overhead work. Again, performing work close to the body. Ensure that your arm is free to rotate. You have sufficient space to move, that you're not cramped in one spot. Ensure that the tasks completed overhead have low precision requirements. Again, they're not requiring fine motions that are going to require so many muscles being used at one time that they're going to fatigue. Use lightweight tools as a result as well. And also, pay attention again to what your body is feeling. If you're having discomfort, that's a clear indication that something's not right.
Thanks, Trevor. That was fabulous. Lots of really, really good information there. There are only a few questions so far that I've noted in the chat. The first one, Trevor, was It came around the area in which you were speaking about osteoarthritis. The question is, what is the effect of thyroid dysregulation?
Okay, so the systemic disorders. So again, it's anything that's going to have an effect on blood flow and blood supply uh, is the main thing. Again, the main thing about the shoulder, and I've said it many times, it's an area of very low blood flow. So anything else that can possibly affect blood flow within the tissue is going to have an effect. Anything that can cause swelling of the muscles, or example, because once you get the swelling of the muscles, it again is going to compress the nerve and also the blood vessels. Anything that limits the amount of space between the clavicle and the tissues is what's going to end up causing those problems.
Would a pinched nerve affect or potentially cause a tear?
No. A tear itself is a tear of the actual tendon of the muscles. It has nothing to do with a neurological response. So any damage to a nerve isn't going to have any effect on a rotator cuff tear. It could have some effect on symptoms for thoracic syndrome because there could be some compression, but could also have just a general radiculopathy that, depending where the level of pinching is or compression, that could cause radiation into the arm itself. Uh, but actually have an effect on a tear, no.
Okay, so the next one, another pinched nerve question we have here is, how likely is it that a pinched nerve may or may not cause arthritis? I guess you pretty much answered that.
Yeah, it's not going to have any effect. Again, osteoarthritis is basically caused by sustained time in awkward positions, resulting in a reduction of blood flow.
Okay, so the next one we have here, I think it's the next one anyways. Um, what is frozen shoulder?
Okay. Basically, the frozen shoulder is less of a condition and more of a response. It's normally caused by the swelling within the tendons themselves. So it's more of a systemic response that where movement and pain. No, it basically becomes very painful to move your arm, and as a result, you can get sort of a swelling of the sheaths within the glenohumeral joint, for example. Uh, that can actually, and it can also result also from scar tissue as well. So it's more of a response than it actually is a condition itself.
Yeah,
It's also, I mean, it's also known as adhesive capulitis.
yeah, and I was gonna just add to that a little bit, Trevor. It's like, yeah, when there is an injury within the shoulder, when people tend to favor that injury and not move with their shoulder, um, all of the structures tend to tighten up, right? So in addition to the swelling and the injuries that are happening at the shoulder, the lack of movement when a person, say, for instance, puts himself in a sling type position for long periods of time, that lack of movement causes those structures to tighten up and shorten up, which creates an effect where it makes it much more difficult to move the arm, and then um, it's kind of termed as though the shoulders is frozen there. So next question, Trevor, that we have here. Um, in summary, what are the 4 E's?
Explain, examine, explore, and expand. So
There
explain
you
the
go.
anatomy of the shoulder, examine the common risk factors, explore the common injuries, and expand upon prevention measures.
So would you say explain, examine, explore,
Explore and
and
expand.
expand? Okay. If a worker performs repetitive work, trimming with scissors over an 8 or 9 hour period for multiple days a week, are the stretch breaks every hour enough for the muscles? Does that give enough time for the muscles to recover?
I'm assuming that they're working sitting and working at an elevated area. Uh, Chances are probably no. What they should be doing is more of a prevention measure. If they are working on a work surface, lowering the desk down or raising the person up, something to try and allow for the maintaining of a neutral posture so that the arms are never elevated or away from the body to begin with.
Okay. So last one here. It's regarding work relatedness. If there is an absence of progressive deterioration, so no prior tendonitis, a sudden diagnosis of a tear with no specific trauma or accident evident, would this be significant in terms of determining an occupational or non-occupational injury?
Interesting question because I mean, the one thing to know is most rotator cuff tears, that's exactly how someone ends up getting diagnosed with them. They're symptom free, no pain, nothing, and then boom, they have a tear. Again, the reason for that is the way that the tendons are structured, as that suspension bridge example I gave, uh, that they bear the other loading. So, I mean, as I said, people can have a tear and not even know it until the onset of pain. So there's that one incident that brings it on. Um, so no, I mean to say one's non-work related versus work related, I don't think you. That's not going to allow you to determine one or the other. Uh, what you need to do to see if it's work related is actually look at what the person was doing. Were they spending significant years' time working with their arms elevated up overhead away from the body, subjected to the risk factors that we were listing, including vibration, etc.
Okay, so we will end it here. Thank you very much, Trevor. That was a fabulous presentation. Thanks for um, the great answers to the questions as well.